Good morning, everyone. Welcome to the Cardiac Arrhythmias Lunch and Learn. We will get started here in about 7 or 8 minutes just to allow time for everybody to jump on this call. Thank you. Hi, everyone. For those of you just joining, we'll give it about 5 more minutes to allow people to settle in before we start the presentation. So feel free to go get a coffee or something to drink or a snack, but we will be starting at about 2 minutes after 12 Eastern Time. There are still quite a few people still entering this presentation, so we'll give it about 2 more minutes and then we'll get started here to allow everybody to settle in. All right, looks like the attendees are starting to slow down a little bit. I'm sure more will trickle in as we go, but for the sake of everybody else's time, we'll go ahead and get started. Good afternoon, everyone. This is the first Lunch and Learn of 2025. Today, we're going to be presenting on cardiac arrhythmias. A little bit of background on these Lunch and Learns and what the format is and what it's going to look like moving forward. I just like to take a couple minutes to talk about that first. So the reason why we chose cardiac arrhythmia is we see that this is a common diagnosis that we as clinicians know how to do clinically speaking, but our documentation tends to suffer a little bit and we don't tend to be as accurate as we need to be when documenting. As we audit certain charts here at Vatica, we will see there are different diagnoses, and so the subsequent Lunch and Learns are going to all be guided by this audit per se that we're going to be doing to ensure that we're actually being active in finding the diagnoses that providers are struggling with from a documentation standpoint. A lot of the times this has to do with the idea that what we are taught clinically doesn't always mesh completely with the coding world. So these different presentations, different diagnoses that we approach are really going to be bridging that gap between the clinical world and the coding world. It is not about burdening you as the providers with extra information or having to document more or write more. It's about being precise and making all of the words that we use count. So hopefully there are some tips and tricks that make everybody more efficient in their day-to-day practice. For the sake of bandwidth and the actual audio feed, we were having some issues earlier. I will be shutting off my camera as I move forward with this, but please feel free to stay on because at the very end of this presentation, we will open up for live question and answer. Anything in regards to cardiac arrhythmias or any other burning risk adjustment question you have, we would love to answer. So a little bit about myself. My name is Jake Utash. I'm a family medicine physician by training. I currently serve as the medical director here at Vatica Health. I'm a certified risk adjustment coder. I've been doing provider education for about 8 years now in the Medicare Advantage risk adjustment space. As far as the agenda for today, like I talked about, we're talking about cardiac arrhythmias, and really we want to explain that gap. Why is it that providers know how to diagnose a specific arrhythmia, but then ultimately the documentation doesn't accurately reflect that specific diagnosis? So we'll dive into some of the anatomy and physiology, even a little bit of electrophysiology of the heart, a quick anatomy 101. I'm sure all the clinicians on this will absolutely know what we're talking about, but for everybody else that's part of this call, we'll give them a little bit of background. Excuse me. After that, we'll talk about the condition-specific documentation tips. We'll dive in specifically to that atrial fibrillation, that sick sinus syndrome, all of these specific arrhythmias that we tend to see are not adequately captured in documentation. Again, this is not always about documenting more. It's about being precise with what we document and ensuring that it's specific to the condition that we're approaching as clinicians. So, simple start, definition of cardiac arrhythmias. Very simple, arrhythmia. It is not having a normal heart rhythm. This could be atrial, it could be ventricular, can even be junctional. We won't spend much time on that today for the sake of time that we do have. These patients can be symptomatic, they can be asymptomatic, and we notice aberrancies on EKG evaluation for other reasons or other conditions that we're evaluating. It can lead to cardiac arrest, heart failure, it can be a cause of stroke or CVAs, and often these things are exacerbated by alcohol, tobacco, obesity, and multiple other things. So the anatomy lesson. I really love this picture because it actually shows the heart anatomically correct in relationship to where it is in the chest cavity. So when I look at my patient, this is an anterior view of the heart, what it looks like when I see the patient. And the reason why this is so important is later on when we talk about the electrical pathway or the electrical conduction system, understanding where leads are, how that electrical system or how that electrical impulse is conducted, it gives us a good idea of what's going on with the heart and where in the heart this is going on, simply based on lead placement in relationship to the electrical system of the heart. So, quick anatomy review. We start over on the right side of the heart. We have that superior and inferior vena cava that dump into that right atria. Right atria also is home to the sinoatrial node, right? The pacemaker of the heart. It's an autorhythmic group of cells, usually pacing somewhere between 60 and 100 beats per minute. More specifically, this can take sympathetic and parasympathetic intervention, allowing that heart rate to speed up or slow down in normal circumstances. From that right atria, we go through the AV or tricuspid valve down into the right ventricle, which then ejects the blood into the pulmonary system, out through the pulmonary artery, one of the lower oxygenated arteries of the entire heart or the entire body specifically. That blood picks up some oxygen in the lungs, comes back in through the right and left pulmonary veins that drain that oxygen-rich blood into that left atria down through the subsequent AV or mitral valve into the left ventricle, which then ejects the blood into circulation through the aortic arch and through the aortic valve. Knowing the flow of blood is super important when looking at different conduction delays, because different conduction delays or different issues or restrictions in the blood flow can lead to different EKG aberrancies and ultimately different disease states, and we should document as such. So what does that mean for blood flow? How do we actually get the contraction or the systole of the heart or systolic function of the heart? We have that SA node generates an impulse. It sends that electrical impulse or rapid depolarization through the atria, both the right and left atria. It is then held as a gatekeeper in the AV node, which is right there in the middle. AV node then sends it down through the bundle of His, through the left and right bundle branches respectively, and out through Purkinje fibers, allowing contraction of the ventricle. It's really important to see how that works, since the conduction system can conduct the electrical impulse faster than the cardiac tissue. It allows that electrical impulse from the AV node to reach the apex first, and then from the apex generates contraction at the apex, allowing expulsion of the blood or whatever is found within the ventricles, which is how we can calculate ejection fractions and ultimately push the blood out into circulation or through the pulmonary vessels. We can often see errors within the conduction system, and how we are going to approach that is saying, is it fast? Is it slow? Is there a block somewhere, based on how we know how the electricity passes in the system? We also want to say, is it coming from the atria? So is this an atrial arrhythmia or atrial in nature? Or is this just simply coming from the ventricles? These can be often seen based on EKGs and based on different things we're going to talk about in just a moment, different electrical impulses or things that we may see specifically on an EKG. The main thing here is knowing that the heart, the way it sits anatomically in the chest, we have a very good picture of what is contracting and what may be enlarged when we translate the electrical impulses onto that EKG. This looks very similar to the last slide, and that's purposefully done. This is assuming lead 2 of a 12 lead EKG. Everybody reads EKGs a little bit different. Most people say, first off, is this a properly calibrated machine? And then we'll look further into it and say, is there a rate, rhythm, axis? And then some people go and say, are there chamber enlargements, which is usually seen based on looking at the wave, like the P wave. Is there a P pulmonale? Is there a P mitrale? Do we know if there's an underlying pulmonic condition or pulmonary hypertension that could be leading to this? All these things can be seen on the EKG. We're not going to dive deep into that. The idea is that this electrical impulse is specifically in lead 2, like you see right here. This shows the visual representation of the anatomic contraction and relaxation of the heart in relationship to the electrical impulse. So as I stated earlier, we have that rapid depolarization that starts for atrial contraction. So SA node sends rapid depolarization through the atria. We have a P wave. Is the P wave the actual contraction of the heart? No, it's technically measuring the electrical impulse. There's a slight delay of the contraction based on the impulse, but it's a good indicator of atrial activity. And it can be seen in different leads, and it means slightly different things based on the lead or the orientation. But in general, we know that that P wave is a good indication of the conductivity of the electrical impulse through the atria. Then we know that there's that AV nodal junction. So we have this little pause or this space, which can often be interpreted as that PR interval or the PRI. And then we have the QRS complex. This is often indicative of that rapid repolarization or depolarization, of the ventricles, which would very closely follow contraction. And then we have that T wave as we come through. That T wave is ultimately the relaxation of the ventricles. Within the depolarization and repolarization, you find that ST segment, or you see the QT interval. There's different intervals or segments that we always look at, and those give us an indication of the actual contraction of the heart itself. Again, we're not going to bore everybody with the anatomy and physiology. Most people absolutely understand all of this, but seeing a quick visual representation of these different phases of the heart also hopefully stimulates in your brain, hey, I do this every time I look at an EKG, and I don't even think twice about it. I believe a lot of clinicians are automatically doing this when they see someone that's coming in for symptoms, or in general, if we have an EKG for whatever reason, we have our very standardized way to dive in and look at what the heart is doing based on the conduction system, and then we can tell whether or not there's an active arrhythmia or not, or like I said, other aberrancies, including atrial or ventricular enlargements and so on and so forth. The key is that we are doing a lot in our head as clinicians. We don't often translate that well into our documentation. So how do we evaluate the actual arrhythmia? The idea is history, history, history. In medical school, oh my goodness, everything was always about the history, history, history. Yes, there's physical exam, there's labs, there's imaging, there's testing, but the history was very much so drilled into our head. A complete history is really that key that unlocks everything else. So complete history happens. All the clinicians on this call know how to do it, right? You know what to do. It's in your head. You can probably close your eyes and run through an arrhythmia decision tree very quickly, because that's what you're doing daily almost, right? Especially for this population, Medicare Advantage population, the elderly population, there's a lot of AFib and other arrhythmias. When we take the history, there's going to be symptoms and timing of those symptoms. We think about it, but we don't often document it. So if this is an initial history for an initial compilation of symptoms, someone has dizziness, lightheadedness, palpitations, chest pain, pressure, sometimes tinnitus, right? Jaw pain, neck pain, you name it, whatever is going to tell us that we need to get an EKG, document those symptoms and those timings. That is absolutely going to help in the support of the underlying condition or your total or full assessment of what the patient ultimately has. Then you look at the underlying conditions. Is this new? Is this a new symptom on an old disease? Or is this a new disease? Is this an exacerbation of something? Is this now a relationship of two different conditions coming together, creating a new compilation of symptoms? All of this, again, you are doing as the clinician. You are driving the bus. Unfortunately, we don't tend to see this very well in the documentation. And then finally, based on the symptoms, the timing, the history, and the physical and everything you've done, you can now order labs, right? There's going to be lab abnormalities. When it comes to arrhythmias, we're often looking at PTH, we're looking at electrolytes. Is the person anemic? Do we have any other etiologies that could cause this from a specific lab or other conditions we're looking at? We're going to draw those labs and look at those. Document it. If there's a lab that makes sense as to why the person's consistently tachycardic or bradycardic, right? If our TSH is abnormal and the relationship makes sense to what the arrhythmia is, document it as such. And then finally, there's all types of testing that we can look at, right? And this can be anywhere from the simple in-office EKG, a 12-lead EKG, all the way to different types of event monitors, Holter monitors, and then even specialist consultation. And when it comes to arrhythmias, we could be looking at cardiologists, EP, docs, you name it. There's a million different things. But ultimately, that evaluation produces a ton of information, most of which never makes it into the actual documentation or chart. Now, am I saying that everything has to be documented with paragraphs and paragraphs? Not even close. We document pertinent positives and pertinent negatives that help support or help act in not only support, of that condition, or they tell us that the condition is not active and it might be something else. That's what we document. So what we're looking at, just like we see on this slide, is everything I just talked about. All of the symptoms, the testing, what is the plan, are they on medications, and is there other additional treatment that we're looking forward to? Document as such. This does not mean document in a ton, and let me show you. So here's a quick clinical case. We have our 68-year-old male, vital signs relatively normal, BMI is 36, so not normal there. Has hypertension, history of sick sinus syndrome, had a pacemaker implanted, has hyperlipidemia, some obesity, taking meds, no difficulty with the meds or side effects, home monitoring their blood pressure 2 to 3 times a week, which is fantastic. No complaints of palpitations, lightheadedness, chest pain, or pressure. Recently started the low sodium diet and is walking on the treadmill 3 days a week for 30 minutes. I mean, this is a miracle patient. I will tell you right now, this is usually not the case with most patients I've seen, even though it may be part of my treatment plan, but great. There's not a lot of documentation that's here, and this basically supports everything that's going on. We look at a concise physical exam, person's alert, cardiovascular, regular rate and rhythm, we don't hear any murmurs, breathing well, no wheezes, rails, abdomen soft, tender, obese. There's a little bit of trace edema in the bilateral lower extremities. That's the note. It's not a lot of documentation. Different EHRs help us get to this very quickly using check boxes, but ultimately we're documenting pertinent positives, we're documenting pertinent negatives, and we're documenting the presence of any type of interventions that have been done on specific conditions like the pacemaker implantation. Unfortunately, as we document that as providers into our progress note or encounter for the day, our assessment tends to look like the one here on the left. We see hypertension, continue current medication therapy, diet, exercise, hyperlipidemia, doing the statin and diet and exercise, and obesity. And then we continue on our day. The reality is we often miss some of the most important diagnoses that a patient has that we actually assessed. We documented, we assessed, we just didn't put in our assessment and plan. So for this patient, I would argue the most important thing that was evaluated was actually the presence of the sick sinus syndrome. We asked the patient about how they're doing, how are they feeling, are they having palpitations, lightheadedness, dizziness, all of the symptoms they had that led to the implantation of this pacemaker are now relieved. That means the intervention, the placement of the pacemaker is working and they're continuing to do well. And this brings me to the first point of this disconnect from clinical practice to our documentation. Clinically speaking, every provider knows how to document this, has that same note that I probably had above, maybe even has more documentation than the note. But very often they still neglect to show that they took care of this condition as an active condition. Why? Because in our minds, we say they have a pacer. They're being paced. The rhythm's gone. The symptom or the arrhythmia is gone. Their normal rhythm, and they are no longer showing symptoms. Everything's working well. But the reality is, if that implantable pacemaker stopped, or if it was no longer there, would the person go back to having symptoms and have the original disease that we talked about? Most likely, yes. And so the reality is, in a patient that has sick sinus syndrome, if they are being paced with an implantable pacemaker, we are still aware of it. We are still evaluating them for that. But even though the symptoms have now subsided, it does not mean that the actual disease has resolved. It's no different than the hypertension we're taking care of. This person had controlled blood pressure. Why? Because we had pharmacologic intervention as well as diet and exercise. They're following their treatment plan, and because they're following the treatment plan, they were not out of normal as far as where their labs, or excuse me, where their vital signs should be with the blood pressure. However, we still every day say, oh, they still absolutely have hypertension, because if we removed all of that intervention, they would absolutely have an elevated blood pressure. It's no different with the presence of a pacemaker and sick sinus syndrome. So for the third time, this is one of the key points for atrial arrhythmias. If there is an implantable pacemaker on a sick sinus syndrome patient, that does not mean resolution of the underlying condition. So if you are evaluating the condition, it is still considered active. We can document as such. And I will show you why in just a moment. And then finally, being as specific as possible in our documentation is also helpful. So instead of just saying obesity, let's call it morbid obesity. Why? Because, well, let's call this patient morbid obesity because they are. What is morbid obesity? It's a BMI greater than 40. This person did not. They had a BMI of 35. It's also a patient that's 100 pounds greater than their ideal body weight, or a BMI of 35 to 39 with obesity-related comorbid conditions, as this patient has. The reason why it's important to be specific here between a regular obesity or morbid obesity is the layer of intervention. This patient doesn't appear to need any subsequent intervention outside of diet and exercise, but if it consistently was not working and then we tried pharmacologic intervention and that too did not work, and the person really still wanted to lose the weight and was motivated and doing everything right, with the diagnosis of morbid or severe obesity, they are now qualified for the possibility, at the very least, evaluation of bariatric surgery. And we do not want to deny our patients any of the possible treatment modalities out there for their disease. Again, is this person necessarily ready for that right now? Probably not, based on the documentation, but it's good to start the documentation to state where they truly are from an accuracy standpoint. This is the coding clinic. We're not going to read through it, and it talks about the presence of a cardiac device with that sick sinus syndrome and how it's still truly an active condition. Look at another quick clinical case here. Now we have a 72-year-old female, vital signs normal, BMI a little elevated at 30, almost 31, has hypertension, history of AFib, status post-ablation 2 months ago, hyperlipidemia, obesity, taking her meds, no complaints of difficulty taking the meds, no palpitations, lightheadedness or chest pain or pressure, appears to be in a regular rate and rhythm on physical exam, lungs are good, and extremities have good distal pulses with trace edema. Great documentation. What do we see, though, ultimately for the assessment and plan? Unfortunately, what we end up seeing is we see that this person has just hypertension, hyperlipidemia, and obesity. When the reality is, this patient definitely still has atrial fibrillation. Now, this one is a little bit trickier because what I didn't show was the med list. So this person is status post-ablation, but it was only 2 months ago. And very often, right after an ablation, our patients will be placed on some type of antiarrhythmic. There are different reasons for this, and there are also different antiarrhythmics that we would choose based on the structural integrity of heart, right? So if there was structural heart disease, we'll often look at this Multac or Cordarone. If there is no structural heart disease, sometimes we can do this Tambicor or flecainide or even propafenone, right? The pill and pocket type thing. And so the idea is that we need to really look at the medications after an ablation and say, is the person still being treated? And this is the same logic with sick sinus syndrome and a pacer. Yes, the person is in a regular rate and rhythm right now. Was it because of the actual ablation procedure, or is it because of the Multec that they are currently taking that is an antiarrhythmic? We don't know. So in the presence of continued antiarrhythmic or continued specified treatment for atrial fibrillation, we consider that an active condition. If that atrial fibrillation, if the patient came in, and had a normal exam and was on no medications to treat the atrial fibrillation status post an ablation, then yes, it is a history of, it is no longer an active condition that can be transitioned into the past medical history and continue just as you normally did with the prior plan that we had. Excuse me. So for atrial fibrillation, the key for documentation here is what is the type, what is the status, what is the severity? We've already talked about all of this earlier on, but the key bridging points, when does it go from being active to inactive, or from active to history of or placed into the past medical history? Implantation of a pacer or an AICD, the presence of an ablation, all of these, which seem to be definitive treatment for the underlying disease, doesn't necessarily mean it is definitive treatment for the underlying disease. So if they're continuing treatment with the antiarrhythmic or even anticoagulation specified for that condition, then it is still active, undergoing active treatment. Here's a coding clinic that discusses that. These are mainly placed in here so that when we disseminate this information to everybody, they can have this as a quick review. I'm not going to read through the whole thing. And finally, today we're going to talk about ventricular arrhythmias, following the same format of what we saw with atrial arrhythmias. The idea is document the symptoms, document the testing, document any consultations, the medications, and ultimately what additional treatment's necessary, right? A quick list of types of ventricular arrhythmias. We have reentrant ventricular tachycardia, we have unspecified, we have Torsades de Pointes, we have the other ventricular tachycardia, and everybody on here saying, how is that possible? We are working in the outpatient setting. A sustained ventricular tachycardia is a non-perfusing rhythm. It is not compatible with life. So, can you see those in the outpatient setting? Yes. Hopefully they are few and far between. What would the documentation look like for that? Hey, person came in, was doing fine, became lightheaded, passed out. They're found to be in VTAC, VFib. ACLS protocol was taken. Patient was subsequently transferred to a higher acute or more acute facility, right? Very simple. The documentation is that this is a very acute thing. We gave acute intervention. What about that patient that has a non-sustained VTAC, or that has intermittent dizziness and then has a full evaluation from cardiology, come to find out after having different types of monitoring devices placed, we notice that they're having intermittent bouts of this non-sustained VTAC. Then is it still VTAC that they're having? Absolutely. Should we document it exactly as it is, a non-sustained? Absolutely. What often happens? Well, based on the presence and the frequency and the duration of the type of ventricular tachycardia, they'll often have an AICD placed, right? The AICD, again, does not remove the underlying disease state. Now, could this potentially be due to electrolyte abnormalities or an underlying condition? Absolutely. And in the presence of removing or correcting the electrolyte abnormalities, or removing or controlling the underlying condition, could we have resolution of it? Absolutely. It's cured. It's no longer an active condition. But is it possible that the person has an AICD and gets shocked once or twice a year when they run into one of these ventricular tachycardias? Absolutely. So the presence of the AICD and the presence of this firing of the device, or on interrogation of the device, if the readout of the interrogation says, yeah, they're still having this non-sustained VTAC, maybe it didn't meet the threshold for shock for whatever reason, whether it was duration or intensity, then the end result is it's still an active condition. So we as providers absolutely do see ventricular tachycardia in the outpatient setting, and we need to document as such. Now, if we're saying they have ventricular tachycardia, I sure hope they have some type of AICD or some significant cardiac intervention that's either planned or a life vest on or something to say that we're aware of it. Those are the little pieces of documentation that need to be there to support it. But it also shows that it doesn't necessarily mean cure because they have an implanted AICD, especially if it's still firing to control the overall symptoms of that disease state. Again, a coding clinic to explain that. And finally, documentation. That blue column is everything we've already talked about. So this clinical documentation, right? A non-sustained ventricular tachycardia, status post ICD. What does that look like when we ultimately, code it, right? We as clinicians write the diagnosis, but that diagnosis or descriptive narrative gets turned into an alphanumeric code. What does that look like? That's that I-48.20. That's what it would look like if we had that NSVT. Well, thank you everybody for listening. I just wanted to give a quick shout out to all of the other educational objectives we have here. We do have 3 live webinars that are going to be offered for CME credit. The first one has already happened. There will be 2 more coming up, and these will also be available on demand, each for 1 credit. We are also going to be doing these monthly lunch and learn webinars. As attendance goes, this was very well attended. If it continues like this, we might actually boost these to every other week. The goal of these specific lunch and learns, again, it's seeing the gap between clinical and coding practices at the condition level. They're meant to be just like this, about 30 minutes, 25 minutes of total talking time. And as you'll see, I'll be done right after the slide, and I'll stay for 10 to 15 minutes for questions that you guys have. Otherwise, if you have to jump right now, please feel free to email us at providereducationsupport@vaticahealth.com. We are always monitoring that in basket and would love to hear your questions and respond to them as we can. But I will now open it up to any questions. I believe someone's been monitoring the chat if there have been some messages there, and we can jump into those right now.
Hi, Dr. Utash, it's Kim. And I'm looking, I don't have anybody that's raised their hand for a question or posted a question in the chat box as of yet. We can give people another minute or so to see if they, if any more questions pop up.
And again, these slides will all be available. They will be emailed to you after the presentation.
Okay, we have a question. Can you please go back to the previous slide? They want to scan the QR code, please.
Absolutely. I probably should have left it on this in all fairness.
Okay, there you go. All right, any other questions for Dr. Utash?
All right, well, I guess we'll give everybody some time back. Again, appreciate everybody jumping on this call today. If you have other questions about other specific conditions, if we see a trend or we see a bunch of questions for a specific condition that we don't see a trend in our audits, we would love to be able to present on that as well for the benefit of everybody. So please reach out to us, tell us where you're having concerns or trouble, and we will absolutely look into it and see how we can help. Otherwise, thank you very much, everybody. Have a great rest of your day.